Single chamber pacing. Classification of pacing modes. 1. Ventricular pacing, ventricular sensing, inhibited mode, VVI. 2. Atrial pacing, atrial sensing, inhibited mode, AAI. 3. Dual pacing, dual sensing, dual mode, DDD. 4. Ventricular pacing, dual sensing, dual mode, VDD. 5. Dual pacing, dual sensing, inhibited mode, DDI. 6. Dual pacing, ventricular sensing, inhibited mode, DVI. 7. Ventricular pacing, no sensing, no response, VU. 8. Atrial pacing, no sensing, no response, AOO. 9. Dual pacing, no sensing, no response, DU. 10. Cardiac resynchronization therapy, CRT. The VVI pacemaker utilizes a single lead placed in the right ventricular apex. VVI intervals. The following intervals are programmed in VVI pacemakers. 1. Lower rate interval, LRI. 2. Ventricular refractory period, VRP. 3. Escape interval. Lower rate interval, LRI. The lower rate is the minimum ventricular rate decided for a particular patient. The device is programmed so that, if the patient's native ventricular rate decreases below the desired lower rate at any time, the device should pace the heart. The desired pacemaker lower rate is converted into an interval, in milliseconds, called the lower rate interval. Since this is the interval between two successive ventricular events, it is also called ventricular to ventricular interval, or VV interval. Since 1 minute equals 60,000 milliseconds, the VV interval is calculated as follows: VV interval equals 60,000 divided by pacemaker lower rate in beats per minute. For example, if the desired ventricular rate is 75 beats per minute, the VV interval will be 800 milliseconds. The ventricular refractory period, VRP, starts after a paced or sensed ventricular event, to prevent responding to unwanted signals. The escape interval is the interval following the refractory period, extending to the end of the VV interval. During this period, the pacemaker is allowed to sense and respond by inhibition. That is, on sensing a native ventricular event, the pacing output is inhibited. Based on the above discussion, the VV interval is equal to the sum of ventricular refractory period and escape interval. VVI operation mode. It is the VV interval that dictates the response of the device to the native rhythm. Following a ventricular event, paced or sensed, the pacemaker time clock starts a new VV interval. If a native ventricular event is sensed before the end of the VV interval, the pacing output is inhibited, the VV interval is interrupted, and the device is reset to start a new VV interval. If no native ventricular event is sensed till the end of the VV interval, a pacing output is delivered to pace the ventricles. Beat 1 is paced. The time clock started a new VV interval, which ended without native events. The device paced again, beat 2, and a new VV interval started, during which a native event, beat 3, is sensed, pacemaker is inhibited, VV interval interrupted, and a new VV interval started, at the end of which pacing occurs, beat 4, and so on. Blanking and refractory periods. In all pacing modes, each refractory period starts with a blanking interval, which is a short period of about 30 milliseconds, that completely deactivates sensing in the pacemaker, to protect against 1. Post-pacing potentials in each chamber, and 2. AV crosstalk, that is, sensing of atrial events by the ventricular channel, or sensing of ventricular events by the atrial channel. The rest of the refractory period allows sensing, so that events are included in the diagnosis of arrhythmias, and in the proper function of the pacemaker algorithms, but the sensed event does not reset the pacemaker, meaning that there is sensing but no response. This prevents pacemaker response to unwanted signals, such as the T waves, retrograde P waves, or electrical interference. This figure illustrates the VVI intervals, the blanking period about 30 millisecond, black, the rest of the refractory period, red, and the escape interval, blue, together constituting the lower rate or VV interval. The ventricular refractory period, VRP, starts with the start of ventricular event, and continues almost to the end of the T wave, of the electrocardiogram. Hysteresis. Hysteresis is a programmable function, in which the escape interval is longer after a sensed ventricular event than after a paced ventricular event. This feature is intended to conserve the battery life and maintain an intrinsic rhythm, because the effective rate at which a pacer begins to pace is lower than the actual rate of the pacemaker. The hysteresis interval is longer than the lower rate interval after the sensed native ventricular event, beat 3. Hysteresis, how it works. To establish pacing, the patient's intrinsic rhythm should decrease below the hysteresis rate for one cycle. For example, if the pacemaker is programmed to a lower rate of 70 per minute, and a hysteresis rate of 50 per minute, the patient's intrinsic rhythm would have to decrease below 50 per minute, for one cycle to establish pacing at 70 per minute. To inhibit pacemaker output, once pacing is established, the intrinsic rate should exceed the lower rate of the pacemaker. Hysteresis benefit. Hysteresis gives more chance for sinus rhythm, to preserve atrioventricular synchrony, since it is more hemodynamically beneficial to have sinus rhythm at a rate slightly lower than the lower rate of the pacemaker, rather than initiating ventricular pacing. Hysteresis, in this way, also prolongs the battery life. It is of note that the pacing spike polarity may normally change from beat to beat in the same lead. In this example, one beat does not show a pacing spike, but it is having the same morphology of the paced beats, suggesting that it is also paced. The change in pacing spike polarity, the presence of minute spikes, or even occasional absence of pacing spikes, all are accepted as normal findings, and do not mean pacemaker malfunction. Some of the incidental findings in the paced ECG are shown in this tracing. All beats are paced, showing wide QRS, but the last two beats are capture beats, C, showing narrow QRS, and the first beat, F, is a fusion between the pacemaker and the supraventricular impulse, showing an intermediate QRS duration. A pacing spike is superimposed on the last beat, but does not change its morphology, no fusion, also called pseudo-fusion. The AAI pacemaker utilizes a single lead placed in the right atrium. AAI operation mode. The timing sequences are the same as in VVI, but the VV interval is replaced by the AA interval, VRP is replaced by an atrial refractory period, ARP, and atrial sensitivities are programmed to much lower values, increased sensitivity, to sense intrinsic P waves safely. In AAI, it is the AA interval that dictates the response of the device to the native rhythm. If no native atrial activity is sensed for a predetermined time, atrial pacing is delivered. If native atrial activity is sensed, pacing is inhibited. Disadvantages of AAI pacing. Oversensing of far-field ventricular electrograms may occur due to high sensitivity in AAI pacing. To avoid this problem, a longer pacemaker atrial refractory period is programmed. Possibility of developing AV block is another problem, in which case atrial pacing will not conduct to the ventricles. Many centers do not use AAI pacing mode anymore. To avoid the possibility of developing AV block, AAI should be selected for patients with normal PR intervals. Absence of bundle branch block. Demonstrating 1:1 AV conduction with atrial pacing at high rates exceeding 140 per minute. Absence of atrial arrhythmia. Why AAI pacing is not suitable with concomitant atrial arrhythmia. If there are concomitant atrial arrhythmias, AAI pacing is not a suitable choice, and dual-chamber pacing is recommended, because drug therapy to suppress atrial tachyarrhythmias may lead to prolongation of intrinsic AV conduction, and may prevent conduction of atrial pacing to the ventricles. Additionally, radiofrequency ablation of the AV node may be needed for many of these patients, also preventing conduction of atrial pacing to the ventricles. In this figure, atrial pacing spikes are seen before P waves in some beats, while other beats are native. In this patient with AAI, there is a pacing spike after the PVC, Does this indicate ventricular undersensing? This is one of the tricks in exams. Of course no, simply because in AAI mode there is no ventricular lead. On the other hand, if this was a dual-chamber pacemaker, the ventricular channel should sense the PVC-QRS, and should not give a ventricular pacing spike. This figure illustrates atrial pacing with Wenckebach AV conduction. The AV node cannot handle the atrial pacing rate. Thank you.